objectives include reviewing the structures that pass through the carpal tunnel, demonstrating the median nerve under the flexor retinaculum, and demonstrating the 6 dorsal compartments of the wrist. Above are the structures you are expected to identify in the lab. The graphic on the left is helpful in reminding us of the proximal boundaries of the carpal tunnel, with the pisiform on the medial aspect and the scaphoid bone on the lateral. In the volar examination of the wrist, it is best to start with the pisiform bone as a landmark prior to using the transducer. Palpation of the pisiform bone, followed by placement of the transducer over the pisiform and visualization. The pisiform is visualized and then the transducer is moved laterally to see the median nerve. The median nerve is central as the flattened honeycomb structure in the middle of the screen. Hyperechoic and below the median nerve is the lunate bone, and to the left is the scaphoid. Sometimes the median nerve is hard to discriminate from the flexor tendons in the carpal tunnel. The following 3 maneuvers can be helpful in improving the visualization of the median nerve. The transducer is toggled like a light switch to create anisotropy of the flexor tendons. The median nerve dances under the flexor retinaculum as the fingers are wiggled. This proximal to distal axial sweep contrasts the median nerve against the flexor muscles. The flexor pollicis longus is demonstrated just inferior and left of the median nerve. This longitudinal image demonstrates the flexor tendons with the median nerve superiorly noted by the arrow. The following video also demonstrates the flexor tendons in movement with the median nerve superior and stationary. The pisiform is again localized, and we are able to evaluate the pisiform, ulnar nerve, and ulnar artery. This graphic demonstrates the 6 dorsal compartments of the wrist. The arrow demonstrates Lister's tubercle, which is a helpful landmark in denoting the actual compartments. The patient's forearm is placed in the neutral position. The radial bone serves as a perfect hyperechoic landmark. The end of the radius is palpated, and then a site is marked 2 finger breadths above the end of the radius. Axial imaging is then performed to evaluate the tendons of the 1st dorsal compartment. The pressure of the transducer may cause discomfort in patients with de Quervain's tenosynovitis. Axial imaging over the radius reveals subcutaneous tissue, both tendons, and the hyperechoic radius. A distal sweep will show the tendons separate into 2. In this longitudinal view of compartment 1, it shows subcutaneous tissue and then the tendons on top of the hyperechoic radial bone. The tendons in compartment 2, the extensor carpi radialis longus and brevis, can be made prominent by having the patient make a fist. In axial view from left to right is the sharp hyperechoic Lister's tubercle, the extensor carpi radialis longus, and brevis. Lister's tubercle is palpable by finding the small space between the extensor carpi tendons and the extensor communis tendons and hyperflexing the wrist. Lister's tubercle is the shark fin-shaped hyperechoic structure on the right side of the screen, and just left is compartment 3, the extensor pollicis longus tendon. In the same view, compartment 4 is in the middle of the screen, the large oval containing the extensor digitorum communis and the extensor indicis proprius tendons. From this same axial view, a slight distal sweep will reveal the scapholunate ligament and joint arising from the inferior. Ulnar deviation is performed to confirm stability of the joint. The 5th compartment is sandwiched between the 4th compartment and the round head of the ulna. Extension of the 5th digit demonstrates tendon excursion. After investigating the 5th compartment, a lateral excursion completely over the ulnar head will show the large extensor carpi ulnaris tendon.